The symptoms of dehydration, again, initially there will be maybe some discoloration of urine, and I think urine color is a very important thing when we advise our patients that you should drink as much water that the color of the urine is like on the white side rather than the yellow side. Okay? So generally they start noticing that the urine is becoming dark colored. Then it will be dry mucous membranes or dry skin. Then urine will become more concentrated. They can perceive some burning there. Patient can then have orthostatic hypotension. After that leads to decreased sweating. Then they start having mental disturbances, tachycardia, hypotension, and so on. And then further leading to dizziness, lightheadedness. They may collapse. They may have a syncope kind of experience. All these are signs of dehydration. Okay. Now we come talk about volume excess. So in dehydration, there is nothing. If there's only volume deficit, you replace volume, and if it's isotonic, you replace isotonic. Volume excess, how can there be volume excess? Only in ECF, only in extracellular fluid. So either it is iatrogenic or the kidney is not able to filter out fluid from body. Okay, so these are the two major mechanisms by which. So mostly it is iatrogenic when we are pushing more fluid than what is needed. So that is why knowing how much is needed is important. Okay, this will present as more fluid which is going into interstitial spaces. Okay, so like you're pushing more in plasma, it will remain in plasma for some time, but then it will start seeping out because the hydrostatic pressure now is more. So it will start going out into the interstitial spaces where if the fluid is not supposed to be there, it is there. I think it will create problems. So pulmonary edema happens. Patients will start having ascites or tissue edemas, puffiness, and all that. Then can incite inflammation, and then problems start. Then the second group is concentration changes. Remember, for ECF, we talked that sodium is the major cation. So sodium mainly determines everything in ECF. Okay, so we can have situations where there is hypernatremia with volume excess, or there can be hyponatremia with volume excess. Now we can actually imagine that volume excess with hypernatremia means we are giving more of sodium to body. Whereas if there is hyponatremia with volume excess means we are giving free fluid or like 25D or something which is hypotonic solutions to the body. Or body is not able to filter out free water, which happens, let's say, in diabetes insipidus. Okay. So we have talked about that how to do perioperative fluid management. So based on these rules, we have to calculate fluid requirement, which we have talked about by using 10, 100, 50, and 20 rule, and also include sensible and insensible losses, which we have talked about. Also, then we have to know that how much sodium and potassium we need to give to the person. Okay. So sodium, the basal requirement is 1 to 2 millimoles per kg body weight. Broadly, we always take it as 2. Whatever the body weight is, 2. But also is important to know what is the current sodium level. If the patient is hypo, maybe we'll slightly increase it. If the patient is hyper, the sodium levels are high or hypernatremic, then we reduce it to, let's say, 1.5 or 1. Okay, that way we keep monitoring sodium levels. This is the basal which we titrate it against the current levels. Same way as potassium. Potassium we count as 1 milliequivalent per kg. Again, titrate to the current values. So this is the basal requirement. Now measure these total fluid requirement, sodium and potassium. Mainly, you'll be able to determine a basal level unless patient is losing a lot of different fluids. But these are the major cations. We talked that potassium is for intracellular and sodium for extracellular. You'll be able to take care of most of the things. So how to plan an IV order for the day? Calculate the total fluid requirement. You check for losses and what are the types, like what is the constituent of that loss? Is it brain fluid? Is it GI fluid? It's upper GI or it's lower GI, or it's a fistula or something else, or it's blood. Okay, so you need to check what losses are there. Also do check the last electrolyte report which is available. Then calculate how much electrolytes is needed for per kg. So as fluid requirement, also calculate the electrolyte requirement. And then we have a plethora of choices of various fluids available. Based on that, you create a combination that all these things are fulfilled. This is what we do on a daily basis in watts when we calculate the fluid requirement. So let's take an example. Let's say there is a person, 55-year-old, 60 kg, Ramesh, who is admitted with a small bowel obstruction. Patient is put nil per oral. Okay, is not taking anything. Now, nasogastric output was 1.5 liters of bilious aspirate. It was there in last 24 hours. Vitals wise, person is showing 104 pulse rate. Blood pressure is 110/70. Urine output is 25 ml per hour. Now, here I must tell you that 25 ml per hour is kind of less. Typically, it should be around 50 ml per hour is the normal rate. So this means I think our urine output is less in this patient. Labs value, the sodium is 134 and potassium is 3.2 millimoles per liter. Okay, so what we do? Step one, we calculate the needs. So maintenance fluid, according to this 60 kg, we know it is around 2300 ml by using the formula of 10, 50 and 20. Okay, losses, we know around 1500 ml. Let's assume insensible losses between 500 to 800 ml. Okay. Deficits, we know that patient is in mild dehydration because the urine output is less, tachycardia is there, BP is slightly lower side. So we assume that this there. So we can initially, I think just at the examination, we'll start a 500 ml Ringal lactate bolus for that. So total fluid requirement will be roughly around 4.5 liters in this patient. Okay. So how to give it? Now electrolytes, let's see. Sodium is as per weight, we need around to give 120 millimoles, but the sodium levels is slightly lower side. 135 is the normal. Patient is showing 134. So there is slightly less sodium here. Potassium, we need 60 milliequivalent. But again, patient is severe, like 3.2 is the potassium level, which is severely less. So we will have to replenish it. So we aim to give around 40 milliequivalents more. So which is makes it around 100 milliequivalents. Okay. Also, we know that there is a 1500 ml of GI loss, which we have to replace as such by Ringal lactate. Okay. Or sodium with KCl. Okay. So if you don't have Ringal lactate, you can give a normal saline and then add 20 millimoles of KCl in every vac. Okay, so this is what we know. We'll correct potassium. So finally, these are the options of fluids with there. Again, I'm not going through this table. I don't expect you to memorize this table here and now. But some patterns which the common fluid which we do. The first one is 5% dextrose. Now it has 50 gram per liter. Now normal pack comes as 500 ml. So in each pack of 5D, you will have 25 grams of sugar, which means around 100 kilocalories. Now remember, we said that we need to give 100 grams of sugar every day. So if you're not giving anything else, you have to give 4 vacs of 5D every day to the person. Now you would have seen in your wards that for everybody in post-op, we write this very blanket order of 4 vacs of 5% dextrose. The rationale is this, because we need to give the basal energy requirement of the body. Okay. Let's say some person you cannot give 4 vacs means 2 liters. Somebody is overhydrated or is having pulmonary edema. You cannot give that much fluid. Then you use a higher concentration of dextrose solutions. Like you can go for 10% dextrose or maybe 25% dextrose. So 25% dextrose means it comes as 100 ml bottles. Okay. In 100 ml again, it has 25 grams. So by giving just 4 vacs of 100 ml means 400 ml, you'll be able to give 400 kilocalories. So this is how you can play with different fluid options which you have. Okay. So we have various concentrations available. Same, the other thing which is commonly we use is NS, which has only sodium and chloride. It is, again, this is per liter, not in per vac. So remember this. So 154 is in 1. So around 77 milliequivalents in 1 vac of normal saline, which is sodium and chloride. The osmolality obviously will be combination of which is 154. The another common fluid which we use. Okay, one more thing about 5% dextrose. 5% dextrose is isotonic to blood or to plasma when we give it. But after some time, what happens is this glucose is utilized. Then we're left with 500 ml of free fluid, which is hypotonic. So that's why whenever we give 5% dextrose, it tends to behave as a hypotonic solution, and it will lead to edemas. Okay, so that you need to keep in mind that how fluid will behave after some time. So that to circumvent that problem, we have 5%. We have DNS, which have 5% dextrose as well as normal saline. So this will remain isotonic after some time also. Initially, it may be a little hypertonic, but as very quickly the glucose will get absorbed and then will become as a isotonic solution. Another fluid which we use is ringer lactate, which has sodium, which has potassium, very small amount, which has chloride, and which has lactate. Now, if you see this concentration, it is very similar, not exactly same, but very similar to our ECF fluid. So that is why ringer lactate is a favorite fluid for many of us, because very easily you can give it. Okay, it has bicarb, it has sodium, it has potassium, it has chloride, it has almost everything there. We also use 3% normal saline because sometimes we have to correct sodium which is not getting corrected by giving normal requirements. So sometimes we need to give a hypertonic solutions. Okay, so then we'll replenish these fluids, and then obviously your institution will be getting a lot of energy solutions like TPNs and all that. What I would advise you is to, before advising any fluid, please read through the contents of the fluid.